Welcome to this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMEDPRN. And for PRN members, slides can be found under the Library Entries section of the ACCP Communities website.
So today I'll be covering a journal club on the inhaled amikacin to prevent ventilator-associated pneumonia. Before we get started about talking about this journal, I wanted to kind of cover some of the background information that will kind of put us all on the same page. And so with ventilator-associated pneumonia, essentially a patient gets intubated with the endotracheal tube, and within our mouth, we have oral microorganisms that can essentially get stuck into the endotracheal tube. And this can cause the organisms to form biofilms and essentially grow within the endotracheal tube and cause respiratory tract infection. Additionally, when you look at a patient who gets intubated, there are usually cuffs at the more distal end of the endotracheal tube. And when this cuff is inflated, it causes secretions to kind of build up within this portion of the endotracheal tube. And so a lot of like secretions as well as microorganisms that can appear there. And although the cuff is supposed to prevent air leakage from going through and other materials from going through, there are micropores within these cuffs that allow for the secretion and microorganisms to kind of pass through the cuffs and ultimately can lead to aspiration pneumonia. Additionally, with the inflation of the cuff, you can get damage to your endothelial lining, your respiratory tract. And so this can result in impairment of your immune response, as well as lead for areas where you can become infected. And so how exactly is ventilator-associated pneumonia diagnosed? It's typically diagnosed through a combination of clinical assessment as well as your culture. So typically the cultures will be done through either a sputum culture or a bronchial alveolar lavage. And so if the organism appears on the culture and the patient has worsening respiratory symptoms, typically this would be suspicious and diagnostic for a ventilator-associated pneumonia. There are some diagnostic thresholds to kind of consider, such as like if a patient had a protective specimen brush type of sampling, then the threshold for the diagnosis would be like greater than or equal to 10 to the third colony forming units. Whereas if they did a BAL to obtain the culture, then that's when it would be 10 greater than or equal to 10 to the fourth colony forming units on the culture itself. Before you would establish the diagnosis. And then there's this concept of the use of procalcitonin. Procalcitonin isn't really recommended to be used as a way to initiate your therapy. And so that's just something to kind of keep in mind, as some providers may choose to get a procalcitonin initially, although this wouldn't be a diagnostic criteria for someone with ventilator-associated pneumonia. Just quickly overview of like some of the treatments that are available for ventilator-associated pneumonia. What I really want to highlight here isn't really all the things that you see on the slide, but from most of the agents that are listed here, what we're really covering for ventilator-associated pneumonia is like your Staphylococcus aureus type of infection, your Pseudomonas aeruginosa, or your gram-negative bacilli types of infection. And from the agents that are listed here, they're typically more broader and they'll be able to cover all of these organisms. There are specific criteria of when you would consider covering possible MRSA, such as like if a patient has a higher risk of antimicrobial resistance, or if they're a unit that is 10 to 20% of MRSA infection prevalence, or if we just don't know the exact prevalence of MRSA within the unit, and that's when we would consider using a coverage like vancomycin for MRSA. But overall, there are also criteria of when you would want to cover, like possibly double cover for Pseudomonas. So this would be things like if a patient has risk factor for antimicrobial resistance, or they're in a unit greater than 10% of gram-negative isolates that are resistant to the Pseudomonas, and patients who are in the ICU who do not have any local susceptibility results. And so just kind of quickly cover some of the guideline recommendations. So what we see here is essentially we want to generally cover for our Staphylococcus aureus, our Pseudomonas, as well as some of our gram-negative organisms. The MRSA criteria for coverage are listed there. Kind of talked about them a little bit earlier. What I wanted to highlight about these recommendations is that essentially within the guidelines, you don't see any recommendations for use of prophylactic antibiotic for ventilator-associated pneumonia or to essentially prevent it. However, they did talk a little bit about the use of like inhaled aminoglycoside. And the only time they really mention it is to be used as an adjunctive therapy in combination with your systemic antibiotics to be able to treat a gram-negative bacilli infection. Additionally, they generally recommend to avoid aminoglycosides if possible, and to use other agents if the gram-negative organism is susceptible to it. So I wanted to kind of cover some of the prior literatures that we see in regards to using antibiotic as prevention for ventilator-associated pneumonia. So there is a study by Kalesterski. This was a randomized double-blinded trial comparing gentamicin against your saline. And they essentially administered both these drugs endotracheally 3 times a day. And it was done in our neurosurgical ICU patient population who underwent tracheostomy. They excluded any patient who died or were discharged within 48 hours of admission. And the results of this trial was that they saw a lower rate of positive sputum cultures in the gentamicin group compared to your normal saline group at about 56.5% prevalence compared to 79.3% prevalence in comparison to the saline group. However, we did not see any difference in terms of the mortality or the adverse effects of the treatment. Some things to note about this is that out of all the positive culture, gentamicin did have higher rates of Pseudomonas as well as Providencia species growing, while in the placebo group, they had higher rates of Klebsiella and Proteus organisms. No sensitivities results were reported for this trial, but analysis of susceptibility of gram-negative organism in both groups showed no statistical significant difference. So overall, what we can conclude from this is that gentamicin reduced the colonization of tracheal secretion by gram-negative rods, and it reduces the frequency of respiratory infection. However, it doesn't seem to have any mortality benefit. So in another study by Calvinier, this study essentially looked at patients aged 18 years or older who were mechanically ventilated for about 48 hours. This was a randomized, single-centered, 2-arm, open-label controlled trial that compared colistin to your NS. And essentially, they dosed the colistin through nebulization for 3 times a day. And they did the same thing with your NS solution. The 2.5 mLs were pretty much the same after the solutions were prepared for the colistin as well. They set it for a duration of 10 days or until the patient got extubated. So when we look at the results of this trial, we essentially see that patients who received the colistin had a lower rate of VAPT. However, this was not statistically significant. Neither was the mortality or the MDR rate. And there was also no difference in terms of the one side effect that was reported, which was the bronchospasm. And so based on some things to note about this trial, though, was that the baseline characteristic for the patient was noted that about 70 to 80% of the patient had received systemic antibiotic covering gram-negative bacteria during the 10-day period of the prophylaxis. And patients in both groups had an Apache score of around 19, which indicated about 24% mortality. And infection on admission was noted to be higher in the normal saline group compared to the colistin group, even though this was not statistically significantly different. So overall, when we look at this trial, we can conclude that prophylaxis nebulization of colistin does not reduce VAP incidence. The last trial that was done previous to our trial was a trial by Wood. And essentially, this was a prospective randomized double-blind placebo-controlled clinical trial that compared ceftazidime to your normal saline. And it looked at ceftazidime 250 milligram nebulization every 12 hours in comparison to our placebo of NS nebulization every 12 hours for a duration of up to 7 days. And so they looked at this in patients who were 16 years or older in our trauma ICU on a mechanical ventilator for greater than or equal to 7 days with a known risk factor for post-traumatic pneumonia. And essentially, what we see from this trial was that patient who received ceftazidime had a significantly lower VAP occurrence during the ICU stay compared to patients who only received the normal saline. But no significant difference was noted in the mortality or adverse effects that was seen. The unique thing about this trial also was that although I didn't include it in the endpoints here because I always wanted to include things that we were looking across all three studies, was that they did see an increase in pro-inflammatory markers that were elevated from their baseline when given ceftazidime. So overall, the patients in this trial were generally more severe patients with an Apache 2 score around 20 to 22 in both groups, indicating about 40% mortality. And systemic antibiotic exposure prior to your study was not statistically significantly different between the two groups. So what we conclude from this study was essentially that ceftazidime decreased the frequency of ventilator-associated pneumonia in critically ill trauma patients without increasing the resistance, but it can increase the pro-inflammatory response in the lungs. So kind of putting all of this together, everything that we talked about, why exactly did we do the study on the use of amikacin for inhalation or amikacin inhalation for prevention of ventilator-associated pneumonia? Well, when we look at the statistics surrounding ventilator-associated pneumonia, there's about 5 to 40% chance of critically ill patients developing ventilator-associated pneumonia when they're intubated, and about 13% mortality for patients who have ventilator-associated pneumonia. And based on some of the previous studies that we talked about, it seems like there might be some benefit in using prophylactic antimicrobial inhalation solution to prevent ventilator-associated pneumonia. And ventilator-associated pneumonia has been shown to increase antibiotic consumption, as well as duration of mechanical ventilation, ICU length of stay, and hospital costs, all of which can be prevented if we're able to prevent, or be decreased if we were able to prevent ventilator-associated pneumonia. The hypothesis for this study was essentially a 3-day course of inhaled amikacin initiated after the 3rd day of invasive mechanical ventilation might reduce the incidence of ventilator-associated pneumonia. This was done with the funding from the French government through the French Ministry of Health. And so when we look at the inclusion and exclusion criteria, we see that they included patients who were on mechanical ventilation for greater than or equal to 72 hours. And they excluded any patients who were initially on a mechanical ventilator for greater than 96 hours with a suspected or confirmed ventilator-associated pneumonia, severe AKI without renal replacement therapy, CKD, tracheostomy tube, and receiving systemic aminoglycoside therapy. They were able to get this approved by the National Ethics Committees in France. And so a little bit closer look in terms of the exclusion criteria. What we see is that most of our patients who were excluded were patients who were intubated for less than 72 hours at the initiation of the trial, those who did not provide consent, those who were on invasive mechanical ventilation for greater than 96 hours, and those who had an extubation that was going to be scheduled. And so after looking over about 6,419 eligible individuals, they eventually included about 417 individuals within the amikacin group and 430 individuals within the placebo group. Within the amikacin group, they gave those individuals 20 milligrams per kilogram ideal body weight or NS nebulization solution once daily for about 3 consecutive days. And the patients who were not not given their second or third dose of the amikacin either met one of the following criteria, including if they were extubated, they had an occurrence of AKI, or if the physician determined that the aminoglycoside therapy IV was indicated for the patient. Additionally, something else to know about this trial was that the vent setting as well as sedation, muscle relaxations were all at the discretion of the physician. And so that could have influenced some of the outcomes of our trial. The primary outcome was generally the first episode of ventilator-associated pneumonia from randomization to day 28. And the episode of ventilator-associated pneumonia was defined as a positive quantitative bacterial cultures in a pulmonary sample and at least 2 of the following criteria, including hyperleukocytosis, leukopenia, fever, or purulent secretion with new infiltrates on the chest radiography. They had a ton of secondary outcomes, but some of them would include things like mortality at 28 days and day 90, numbers of days of mechanical ventilation from randomization to day 28, numbers of antibiotic days, as well as number of days with administration of at least 1 systemic antibiotic. And so when we look at the statistical analysis, this was a randomized superiority trial. They estimated about 850 individuals were needed to provide 80% power with a 2-sided alpha of 0.05. The analysis was based on an intention to treat principle, and they did a between group analysis of restricted mean survival time to ventilator-associated pneumonia. And their total group population, the hazardous ratio was calculated using the fine and gray regression model. And so when we look at the results of this trial, we see the baseline characteristics were essentially similar across the 2 groups. What we did notice from this was that generally based on the Charlson comorbidity index score, as well as the simplified acute physiology score and the sequential organ failure assessment score, the patient that were included in this trial was generally more severe patients. The mortality rates the predicted mortality rate was ranging anywhere from like 33 to 49%. And the infections were about a 30 to 33% across both of the groups. And most of the patients that were in this trial had systemic antibiotic therapies with about a 77 to 78% of the individuals within both of the groups having used some kind of systemic antibiotic therapies at baseline. They also had a median of about 3.5 days before initiation on this clinical trial. And so when we look at the outcomes of this trial, we see that they showed that amikacin had a lower rates of first episode of ventilator-associated pneumonia at about 15% compared to 22% in the placebo group. And they also had significantly lower infection-related ventilator-associated complication as well. They were significant for the AKI occurrence, in which they had actually lower AKI occurrence than the placebo. There was no difference seen in the time to first successful SBT trial and hospital death, as well as ESBL and Enterobacter psoriasis. I think the thing to kind of know about this was when we saw the rate of AKI being lower in the amikacin group was a little bit weird to me. And so when we look at some of the baseline data for this trial, we see that when they excluded patients with CKD, they really only excluded patients who had a GFR of less than 30, whereas anyone who were greater than 30, including those who were 30 to 60, which would still be our CKD patients, were included within this trial. And we did see that the placebo group did have more elevated patients with serum creatinine. And so this could be a possible explanation. The other thing is that that patients in the placebo group could have also had more shocks, which could have decreased perfusion to the AKI, to the kidney, and result in more AKI episodes. However, this result wasn't reported, and so it was just more of a speculation in terms of why this could have been a possibility. Overall, when they were classifying infection-related ventilator-associated complications, they essentially defined this as worsening oxygen associated with signs of infection and initiation of antibiotic therapy. And so that's just something to note as we look at some of the graphs that was provided to us, including what the first graph is essentially a look at the difference between inhaled amikacin and our placebo for the incidence of VAP. And we see that there is a gap that's notable in between the treatment group, and this was statistically significantly different. The bottom graph here is just really a zoomed out version of the top graph. And so this is just kind of to help with our visualization of it. They also did talk about ventilator-associated complication, which was essentially defined as worsening of oxygen over 2 days after a stable or improved period. And so we did see that our amikacin group did have lower cases of ventilator-associated complications. When we look at the infection-related ventilator-associated complications, so this is essentially our worsening oxygenation in combination with signs of infection and initiation of antibiotic therapy. And we did see a lower rate of that in our inhaled amikacin compared to the placebo. And then when we look at the possible ventilator-associated pneumonia, we did see a lower rate in our amikacin group as well. And so what were some of the things that were done well and that could have been improved in terms of this trial? So some of the things that were done well was essentially the baseline characteristics were similar between both groups, which means that the two groups being compared were similar to each other. So there's less concern of group differences influencing the result. Most patients included were in a severe condition, so we can apply this to a more higher risk patient population. The use of normal saline nebulization helped to maintain the blinding between the group and reduce bias. The author also did a good job in terms of mentioning that they did not get amikacin level because they did not want the people who were involved to know which individual received which treatment. And so this kind of helps to maintain the blinding of the trial. And at the same time, the problem with this was that we didn't have levels that were obtained. And so this kind of prevented us from correlating if the patient received appropriate exposure to the amikacin group. Additionally, some of the cons from this trial is that it had high baseline percentage of individuals who were on systemic antibiotic. So this could have influenced our primary outcome, as organisms may not have grown due to the use of systemic antibiotic. Physicians also got to decide whether or not the patient should be on systemic antibiotic, which would decide if they should receive the second or third dose of amikacin or placebo. And so this kind of added a little bit more bias towards our trial, as this was something that wasn't standardized or protocolized. And so we don't really know what exactly the effects of this drug might have been if the patient received the whole 3 course. Some of our patients did only receive 1 or 2 doses. Data can also be interpreted up to only 28 days, given that the trial was up to 28 days, and we were uncertain of the prophylactic effects beyond the 28 days. Additionally, they did exclude patients who were on mechanical ventilation for greater than 96 days. So we don't really know if it would be beneficial for patients who've been on mechanical ventilator for a lot longer to be able to start this prophylactic treatment regimen. They also didn't mention what type of organisms ended up growing or causing the ventilator-associated episode. And so the lack of cultural data makes it more difficult to kind of analyze whether or not we should be implementing the use of amikacin for prevention of ventilator-associated pneumonia. Additionally, there wasn't any standardization for a ventilator setting. This was adjusted based on the physician's judgment, which could affect the overall mortality outcome for the patient. And if we were to kind of apply or try to apply the study to our own patient population in terms of them being on a mechanical ventilator, it would be difficult to kind of mimic what was done within this trial, as we don't know exactly what was done in terms of the mechanical ventilation setting. Just some other things to note was that the nebulization solution was, or how it was administered, wasn't really mentioned. And so there's also that factor of unknown when it comes to the administration of the drug. They also didn't talk about anything about maintaining of the equipment that could affect the drug delivery. And due to the lack of the drug level, it's difficult to say if the patient got adequate doses of the drug. There is a liposomal formulation of the amikacin inhalation that was approved in 2018 by the US FDA. However, that was only approved for use in our MAC types of infections. And so, and it was only mainly for treatment. So we don't really have a specific dose in terms of what we should be dosing patients for prophylactic use of amikacin. And so there's a lot of ambiguity to kind of think about and consider when interpreting the data for this trial. So what did the author essentially conclude from this trial? They essentially concluded amongst patients who receive invasive mechanical ventilation for at least 3 days, a subsequent 3-day course of preventive inhalation of amikacin reduced the burden of ventilator-associated pneumonia during the 28 days of follow-up. My conclusion to this study was that the data showed a lower rate of VAP from inhaled amikacin, but the higher rates of antibiotic use at baseline and the lack of cultural data prevents a definitive conclusion to be drawn from the study. Inclusion of CKD patients at baseline is concerning to validate the results of showing that amikacin had lower rates of AKI, and the dosing of amikacin prophylactically is not established, and the lack of data on serum drug concentration makes it difficult to conclude that the patient received appropriate and consistent dose of the drug. And so how can we apply this trial to possibly some of our future practices? I think one way to kind of consider the use of this trial is that patients at higher risk of gram-negative infection, including those who have a history of gram-negative infection, recent hospital visit, units in which they're hospitalized have greater than 10% gram-negative isolate, or they have high risk of mortality, then the use of prophylactic amikacin inhalation might be appropriate. In addition, we should also make sure that the patient's on mechanical ventilator between the 3 to 4 days before considering the use of this. However, there still, I think, needs to be further trials, such as trials that compare additional things like your gentamicin or other inhalation solutions that were compared in previous trials to really kind of assess the efficacy of amikacin, as well as being able to get some of the informations that were missing from this trial that we mentioned earlier. I wanted to acknowledge some of the individuals who helped me with this presentation, including Dr. Maldonado, as well as Dr. Santibanez, for their help in reviewing and putting this presentation together. These are the list of my references that I used, and I would be happy to take any questions that anyone has.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.